again to another exciting presentation. Let me share my topic right away. So today we are going to be talking about common co-occurring medical disorders, and I'm sure everyone is, or almost all, are familiar with what we'll be discussing today because they are topics that are discussed all over. And we're going to talk about co-occurring medical disorders, and we're going to focus today on HIV and AIDS and hepatitis and tuberculosis. I will talk about HIV and AIDS and also talk about tuberculosis, while Beatrice will talk about hepatitis. So let's move on. The United Nations priority. The Commission, UNODC Commission on Narcotic Drugs, 2010, presented this report that UNODC lists 6 challenges related to substance use and dependence that undermine world security, development, health, and social cohesion. Most times our political leaders in the developing world don't tend to see, health in this light. That if we have poor health, it can affect security, development, and social cohesion. And you find that for most countries, particularly ours, the budget for health is not adequate. And HIV, hepatitis, and TB were on that list, top list, 6 challenges related to substance use and dependence that undermine world security, development, health, and social cohesion. And until we relate health to security, development, and social cohesion, I'm not sure we're going to make headway, particularly for those of us who are in this part of the world. So these are our learning objectives. By the end of this module, it's expected that we'll be able to discover 3 common co-occurring medical disorders, discover the relationship between each disorder and SUDs, define drug resistance, and discuss the incidence of and resources for addressing these medical disorders in our various communities. But before then, let's clarify or define some terms. These are HIV and AIDS terminology. HIV, I'm sure almost everyone can tell us what HIV is all about. It's human immunodeficiency virus, and it attacks certain type of T cells, particularly the CD4 positive cells. The T cells are a type of white blood cells which are critical to the immune system because they fight off infections. But the HIV virus tends to attack these cells so that it renders them incapable of actually fighting or warding off infections. And so the victim or the patient or the client becomes vulnerable or susceptible to contracting either infections. There's also loss of CD4 cells. That means decreased ability to protect against infections. When you have a reduced CD4 count, then the individual is not able to actually ward off infections. And when HIV AIDS, came about, and before the advent of highly active antiretroviral drugs, I know they used to stress some time ago that if the CD4 count is less than 200, per milliliter, then you can start antiretrovirals. But nowadays, they said no. Once you are able to diagnose, start treatment. So it's a measure of the viral load, indirectly. T cells are a type of white blood cells critical to immune system because they are cells that are able to fight and defeat invading microorganisms in the body. CD4 count is the number of CD4 cells in a sample of blood. By this, you are talking about a milliliter of blood. How how many viruses are there, what is the viral load. That's what it means indirectly. Then it will tell you how far the disease has gone. If you have a high load, then it then means that there will be quick progression to AIDS, because the individual's immune system will be, incapable of warding off all kinds of infections, and the individual becomes vulnerable or susceptible to other infections, opportunistic ones particularly, then, and that will overwhelm the system. AIDS simply means acquired immunodeficiency syndrome. Let's move on. Terminologies. HIV-1 viral load refers to the number of viral particles found in the blood. There are different subtypes of HIV. So this is HIV-1, you find HIV-2, and others. Even in West Africa, you can get HIV-2. Antiretroviral therapy, ART, is treatment of people infected with human immunodeficiency virus using anti-HIV drugs. That's what simply. So sometimes when we talk about ART, or the highly active one, we'll see that later as we move on. Human immunodeficiency virus, HIV. This is the virus that causes AIDS, or acquired immunodeficiency syndrome, and attacks the immune system by destroying CD4 positive cells. How is it transmitted? It is transmitted from one person to another through body fluids, and these are blood. If you don't screen blood and you transfuse the blood, some people might be HIV positive, or they may carry the virus, and if you don't screen the blood, you might transmit it to a recipient. And in the early days of HIV/AIDS, in fact, several patients who contracted the illness actually got it through blood transfusion, because the blood was not properly screened. Semen, genital fluids, breast milk, these are other fluids that an individual can get infected, and which means that it can be contracted through sex, and also can be transmitted from the mother to the developing fetus or to the child, get it through breast milk. And for that reason, when mothers are infected, most times they're discouraged, from breastfeeding. Sharing needles with an infected person and having unprotected sex are the most common ways HIV is spread, no doubt. The transmission continues. HIV cannot survive long outside the body, which means that if it's outside the body, then it dies out. HIV cannot be transmitted through routine activities such as sitting on a toilet seat, sharing food utensils or drinking glasses, shaking hands, or kissing. If it were so, I'm sure some of us wouldn't be alive at this time, or would have been HIV positive. The virus can be transmitted only from person to person, not through animals or insect bites. And those of us who live in malaria endemic areas, people say, my people, make a joke out of it. They say it's just the mercy of God. If mosquitoes were transmitting HIV, and then many people would have gone by now. So it's not transmitted by insect bites. People infected with HIV who are taking antiretroviral therapy can still infect others through unprotected sex and sharing needles. Sometimes some people are very wicked. They have it, but they are hiding, and they don't want to, to engage in unprotected sex. And because of that, they'll be able to infect their partners. And even when the partner insists that it should be protected, sex, then the rest eyebrows and then cause problems for the partner. That has been a problem. But what are the early symptoms of HIV? First stages of HIV infection, few or no symptoms. Within a month or two after infection, you may experience fever, headache, tiredness, enlarged lymph nodes in the neck and groin area. And in those of us who live in sub-Saharan region with our temperature and all kinds of infections that we battle with, initially it was difficult because you think, oh, it's maybe ordinary malaria fever or typhoid fever, whatever. But we didn't know that people were already infected until it became obvious that people were suffering, and then with more, awareness and education, then people now decided to, look for the symptoms and also test. But before then, many people took it for granted and they were infected. Symptoms usually disappear within a week to a month and are often mistaken for flu. And there are many people too, recall when it started, who resisted tests. Even now, people are reluctant, to go for tests. And during this period, people are highly infectious. But if without a high index of suspicion, you think it's maybe an ordinary flu, but the person would have, contracted HIV. That's why it's good to be able to assess and take a thorough history. And when you take a thorough history, you might get a high index of suspicion, and then you know what to do. Cancel people and test them. Other symptoms are rapid weight loss. And of course, many things can cause weight loss. Recurring fever or heavy night sweats. Extreme and unexplained tiredness. Prolonged swelling of the lymph glands in the armpits, groin, or neck. Diarrhea that lasts for more than a week. So you find that the symptoms are numerous and affect, different systems, in the body. The symptoms continue. Sores in the mouth, anus, or genitals. Pneumonia, and particularly pneumocystic, cardiac infection, and a typical pneumonia, so to speak, that affects people that are immunosuppressed. And the red, brown, pink, or purplish blotches under the skin or inside the mouth, nose, or eyelids. Memory loss, depression, and other neurologic disorders. In fact, in the advent of HIV/AIDS, we were able to diagnose people for the first time when they presented with depression and memory loss. But the depression was not the usual kind of depression. You find a young person come with depression, but so much marked memory impairment and then neurological symptoms. So that made us to suspect that there might be HIV, and then we canceled them and tested them. Lo and behold, they were HIV positive. In fact, some of them had almost come down with full-blown AIDS, because then they go from one hospital to the other, and the symptoms were not typical presentation of HIV infection. And some of them at that time, in fact, many of them didn't survive it because there were no antiretroviral drugs. They were too expensive. They were not readily available, and then they were not the highly active, antiretroviral drugs. As many people died during that time. Each symptom could be caused by other illness. That's what we have to know. But you have to rule out it from your thorough assessment, history taking, that you get to know whether the person come down with an HIV infection, or you need to test or screen, the person for HIV. And the only way to find out whether a person is infected with HIV is to test for the presence of the virus. We got to a point that for those of us who are clinicians, we know we had experience of some patients whom we suspected that had HIV. They dribbled people. They will go and collect blood of some other patients and take it to the lab. And particularly those of them who were using substances. We had this experience. They were using substances, and then they will have maybe one person working in the lab or in the hospital, and they were, using substances together. You send the test samples for tests, then they go and give a fake, result. And we kept wondering, and they really dribbled us for a long time, because the symptoms were classical for HIV, yet the result came out, negative, until we were able to, unravel that mystery and discover that somebody was playing pranks, and then the hospital had to make a new policy. Just like our patients, sometimes we ask them to produce urine for tests, for drug tests. They will go and collect urine from their siblings or from those who have tested negative, and then they'll bring their urine, say this is the urine they are giving you their own urine for tests. But if you don't collect it there and you ask to bring urine, you'll be deceived. HIV symptoms and transmission. It may take many years for symptoms to develop. Some people with, in fact, for 15 years have not developed symptoms while their partners have even gone. And before they'll say, well, if there are no symptoms and then the CD4 count is high, it does not need for treatment. I had a friend that, had that until his wife died, but he married another woman, and then she also came down with it. And he didn't actually tell the woman that he was HIV positive. So it was during routine antenatal care that was detected. But then they insisted that he should start treatment. But at that time, there were no symptoms after almost 15 years, being positive. So an infected person can spread the disease during any stage of HIV infection. People with HIV can remain healthy by detection during the earlier stages of infection. Yes. And then starting treatment before symptoms develop. With that, they live, healthy lives, and the quality of life, improves. And nowadays, in fact, you don't see them with any symptoms. They go regularly to collect their antiretroviral drugs, and they live like every other person, and it's being treated like any other chronic illness now. Treatment reduces but does not eliminate the risk of transmission. So even if they're on treatment, they can still transmit it, because cases have come down. Okay, he's HIV positive, he's taking treatment, and where the viral load is very low, should I marry him or should I not? And the people come seeking for advice. Some people say, I want to marry him because I love him, irrespective of the fact that he's HIV positive and negative. I still want to go ahead. And they come seeking for advice for you. What do you tell them? So now we talk about the highly active antiretroviral treatment. Highly active antiretroviral therapy came on board in 1996, and now it's available everywhere. And the regimen of taking 3 or more anti-HIV drugs in combination, and you take them daily, and that prevents the HIV from multiplying and destroying the cell, because you attack the HIV virus from different points, so that it's not able to resist this 3 combination of drugs, even though for some you still get some resistance, or they are not able to tolerate some of the medicines. But we'll get to talk about that later on. Heart continues. Antiretroviral medication help the body to fight off infections and cancers, because when the immunity is down, then people can easily come down with all sorts of infections and also cancerous growth, because the body can no longer fight any rebellious cells. Then they also delay the onset of AIDS symptoms. For some people, never come down with the full-blown AIDS symptoms. Yeah, they are HIV positive. They don't even come down with that. They will never know until they tell you that they are actually living with the virus. And it also prolongs a healthy life. That's why we should encourage people to test early, and then cancel them, test, and if they're positive, then they commence medication. That helps them to enjoy better quality of life. HIV treatment, when to start? Treatment is recommended to start soon after diagnosis of HIV, regardless of CD4 cell count. I told you earlier on that in this environment, in my own environment, they will look at the CD4 count before they start antiretroviral therapy. But if it's above 200 cells per millimeter cube, they will not even bother to do the start on antiretroviral. But now it has changed. The policy has changed. Once it tests positive, you're advised to start treatment. And particularly HIV infected people with the following conditions. People who are pregnant, pregnancy has a way of diminishing the immunity of pregnant mothers. So you don't joke with it, because it can affect the life of the mother and the baby. So it's the right thing to do to start treatment for those people. And those who have already come down with full-blown AIDS and certain HIV-related illnesses and co-infections, maybe pneumonia, whatever it is, it's advisable to start heart straight away. And also early HIV infection, period of up to 6 months after infection with HIV. Once the individual has come in contact and able to detect the antibodies, if you are to look for antibodies between 6 weeks and 6 months, you'll be able to detect the antibodies. And if it's If they are positive, then or the person has developed antibodies for the virus, then the best thing is to start the treatment. And that's why we don't see, death from HIV/AIDS like we used to have in the beginning of the illness. Before, it was more like a death sentence when you are positive, but now people don't see it as death sentence because of the drugs, and they live, they enjoy good quality of life and they live long. So people are no longer as scared as they used to be. So what is drug resistance? A target bacterium or virus like HIV can grow in the presence of a chemical, the drug that would normally kill it or limit its growth. The medicine or the drug that kills the virus no longer kills because the virus has maybe undergone mutation. And so the drug is no longer effective. And most times it comes because those drugs are abused in the sense that maybe the treatment is inadequate and the patients don't take the medicines for a sufficient period of time to kill the offending organism. So the virus or whatever organism is there can become actually resistant to the drug. In the case of HIV, drug resistance is usually caused by the ability of the virus to mutate and become resistant to certain drugs. And in this case, for you to check for resistance, you have to do you have to check for the genome of the virus and look at the points where mutations have taken place, so that you can actually change the drug for the individual who is positive for the virus. And thank God now we have many drugs available, so that you can juggle with different combinations to get the one that suits or the one that's able to actually kill the virus. So matching HIV medications to patients, what do? Perform a drug resistance test. So, and as I said earlier, what does it mean to do a drug resistance test? You just look for the do some viral genotype, and it detects the points in the genetic code of the virus where mutation has occurred. Then you can now look for another drug that tolerates, and then you prescribe it. Then you monitor success and the comfort of therapy. It's not just the success, but whether the individual is tolerating the drugs or the side effects are overwhelming. So the success is monitored by the CD4 count and the viral load. You look at if the viral load is really going down, or maybe not even detectable, you know that you're succeeding. And if the CD4 count, rises, is increasing, then you know that yes, you're doing well. But if the CD4 count is low and then they have high viral load, it means that the client is not actually tolerating, or the drug is not killing the virus, or is not inhibiting the virus from multiplying. So some level of resistance, then you have to change, and also the comfort of the client. Because if you don't look at the side effect profile and whether the client is able to tolerate, they will not be able to adhere to the treatment. And it's even worse when you have an individual who use substances and also have some co-occurring maybe mental disorders, which judgment is usually impaired. They will just say, no, I'm not taking it anymore. So you do that, and if you succeed, you can now change the medication if it is necessary. If there is a resistance, you can change the medication and then repeat the process all over again. That continues to help the patient to remain in treatment. HIV worldwide impact. Antiretroviral therapy is not always available. Yes, in some places it may be difficult to get antiretroviral drugs, but I know some international donors were able to help the developing countries, particularly the Bill Gates Foundation and others, to provide this antiretroviral, and the government were able to give some counterpart funding to be able to provide this for those who were infected. Otherwise, they will hide and they will keep infecting. But with the advent of antiretroviral drugs, particularly the highly active one, people are encouraged to come to test, and then do well. So in 2015, there are 36.7 million people who needed treatment, but only 54% of them did not receive treatment because they are not available, but 46% of them received treatment. Whereas in 2016, about 18.2 million people received antiretroviral drug according to the WHO and the UNICEF in 2016. So not everybody has access to antiretroviral drugs, but I think governments are making effort. Even the Nigerian government in my own country is making a lot of effort to see that this category of people, have access to these drugs and they are treated. HIV worldwide impacts continues. In 2015, 36.7 million people worldwide with the HIV virus live with it, and then 2.1 million people are newly infected with HIV each year, and 1.1 million deaths caused by AIDS each year. You can see this is really frightening. Again, 1.1 million people dying from an infection. But now, as I said, the death rate has reduced drastically because of the highly active antiretroviral drugs, and because people are coming out to test, and they see it now more as a chronic illness and not a death sentence. But why are we talking about medical conditions? Because they co-occur with people who use substances. It's a big problem among them. And here, of an estimated 11.7 million people who inject substances worldwide, up to 1.6, about 1/7 of them, are living with HIV. So, and that's according to the UNODC, World Drug Report. So these are people who inject drugs because of needle sharing and all kinds of unhygienic practices and lack of protected sex. They're able to transmit these viruses and infect themselves. That's why this idea of providing safe needles for people who inject them, came into being, and that has actually helped to reduce the infection rate, so that if you still inject, then you can get safe needles to inject and not to share with others. But there are gender differences in HIV infection. The following information about HIV gender differences is related to geographical area. It's not a global thing. It doesn't happen, in every part of the world, but some geographical locations have them. The important difference between men and women, for instance, underlying mechanism of HIV/AIDS infection, the lifestyle and so many other things, can, and then the culture too, can lead to differences between men and women, and then social and economic consequences of HIV/AIDS. In some places or in some cultures, you find that the men are given priority. They can have easy access to treatment, but for the women, they're stigmatized. They call them all kinds of names. And then they are even afraid to go out. And even when the woman comes down with HIV positive infection, they tend to blame the woman, but nobody talks of the person who infected her. They just conclude that she must have been, very promiscuous. That's why she got it. And they even say she's the one that gave even the husband, if the husband is positive. Usually that's what happens. So the woman are the receiving end. So you can have a lot of differences. And then there are biological differences too, the anatomy, and some physiological differences that we have. And differences in sexual behavior between the men and the women can account for some of these gender differences. The man, in some cultures, has a lot of freedom, a lot of liberty to do whatever he likes to do. He may be promiscuous. He can marry as many wives as possible. But the woman is entitled to only one husband, and she doesn't have the freedom to behave, like the man. Otherwise, she is, called all kinds of names, stigmatized. So that can account for some of these differences. And differences between men and women in social and cultural roles and responsibilities, yes. And different levels of access to resources and decision-making power. Women in some climes, particularly developing world like ours, don't really have access, the same level, with the men. But it's actually changing now, really changing, and the gap has narrowed significantly. But it's still a men's world. The women are struggling to be recognized, or to be given a say, or even to be given an appointment. It's a men's world, so they have to beg the men to give them, a place. That's what happens in our own climate, certainly not in the developed world. HIV gender differences continue. Worldwide, the gap in HIV prevalence rates among men and women of all ages is narrowing. Yes, it's actually narrowing. And younger women, ages 15 to 24, show higher prevalence rate than men of the same age. But a study showed that of 18.5 million of adults living with HIV who are aged 15 to 49 years, you find out that more of them, in fact, 37 million out of this, most of them were actually women. And you find that in North Africa, out of the number of people living with HIV/AIDS, 54% were women, and even the Caribbean, 52%. That was from the UNIFEM website. That was their report. So you find that in most places, women, are diagnosed more with the HIV, compared to the men. And in our own climate, you find that sometimes the men resist actually going for tests, and they try to hide under several conditions, but they will make the women to go, for the test, and that's why. And transmission too sometimes is 2 times higher, when from men to women is 2 times higher, compared to transmission from women to men. And the same website reported that younger women aged 15 to 24 have an increased prevalence than men, of the same age of getting or contracting the HIV/AIDS virus. And out of 11.8 million young people of 15 to 24 years living with AIDS, 7.3 million out of these 11, in fact, were young women. Just 4.5 were young men. And in sub-Saharan Africa, by the same report, teenage girls have 5 times more likelihood, of getting infected than the boys. So this was from UNIFEM website. So you find a lot of gender differences in HIV infection, even though, as you said, the gap is narrowing. And then early studies showed it was easier for a woman to contract HIV than for a man, but later studies show this probably is due to the viral loading or amount of virus rather than the real gender difference that appear to be the case earlier. HIV, pregnancy, and childbearing issues. In developing countries, high risk of infant deaths associated with maternal HIV infection. Yes, a lot of women were actually infected, and most of them some of them were diagnosed for the first time during antenatal care. And pregnancy-related complications such as hemorrhage expose women to risk of infection related to transfusion of blood or blood-related products. HIV can be transmitted through breast milk. So the women tend to bear the brunt of this HIV in many ways, either through childbirth, or they are the ones that will go, maybe they may be raped, they will go for antenatal care, they have to totally transmit it to their children, and they have to care for those children. The men may even divorce them, and go marry other women and infect them again. So this is the problem that women, tend to face, particularly those living in the developing world like ours. Mothers who decide to discontinue breastfeeding in favor of infant formula reduce the risk of HIV transmission to their child. But if a mother doesn't breastfeed now, it will raise an index of suspicion. Why is it that UNICEF is encouraging breastfeeding, discouraging infant formula, and this woman is now not breastfeeding? She claims she's working and she doesn't have time to breastfeed her baby, and then she's giving infant formula. But that raises an index of suspicion and may expose the infant to diseases resulting from an unclean water supply and to malnutrition. Yes, in developing countries where you don't have good drinkable water, or people don't have access to good water supply, you find that infants whose immunity is not really developed are susceptible to all kinds of problems, diarrhea disease, and all kinds of infections because of unclean water. So the process of giving them feeding outside the breast milk, subjects them to all kinds of diseases, and they tend to die, at infancy. And that's why we have these high infant mortality rates, particularly in countries like ours. Using formula also may alert others to HIV status, yes, and lead to stigma and discrimination. That's very true. And women, most times, it's the women that also have to bear this. So, gender norms. Gender norms increase vulnerability to HIV infection, especially in young people. One international study, WHO, uh, found that many young women knew little about their bodies and contraception and sexually transmitted infections, particularly in areas where they don't even go to school. If you talk of, for instance, my country, you find that a lot of women might not be very knowledgeable about their bodies, particularly those who from the northern part of the country. They are not as enlightened as those from the south because not all of them go to school like those in the southern part of the country. So that affects them, and then the husband might marry 4 or 5 of them. So and they're competing for the same man. They don't even know what's happening, and their livelihood depends on the man. They don't really have a say. And many fear seeking information or sex or condoms will label them as sexually active. Of course, a woman asking for a condom, everybody will raise eyebrow. The first thing that comes to mind, she's a commercial sex worker. She's very promiscuous. And so they hide, they hide and they don't want to do it in the open. But the man can just go and request for a condom. Nobody's saying anything. But for the women, no. So particularly in our own part of the country too. So these are problems that we face daily, and it has not really changed much because change slow to take place, and because of cultural beliefs, religious beliefs too, the change is coming very slowly. Violence toward women also puts them at increased risk of infection. Coerced sex or rape, and people come to attack, terrorists come to attack, they kill, they rape women and do all kinds of things. So that is the problem. And some of them, of course, when they are raping, nobody talks of protected sex. So they are vulnerable. And then the threat of violence when negotiating the use of condoms for safer sex. Sometimes say, I'm going to leave you, I'm not going to marry you, and they threaten them. And because they want to marry, they just have to oblige. And that makes some of them to come down with a HIV infection. Gender and healthcare access. Health programs may be more limited for women or have barriers that men do not have. And that's very true because in some developing countries like ours, priority is given to the male child over the female. So for everything, whether it's education, health, whatever, the priority is given to the boy or to the man. A unique study found that men with HIV were hardly questioned about how they became infected and were generally cared for. In fact, the first thing they would do in some places is to blame the lady, they blame the woman. In contrast, women were often accused of having had extramarital sex, whether or not this was the case, and received lower levels of support. Very true. This is a WHO Department of Gender and Women Health report in 2003. What can HCG counselors do? Provide education on sexual and parental transmission of HIV. Sometimes even when you invite, for instance, we know that when we invite the couple to come, the woman will come, but the man may not come. You have to persuade, and keep cajoling him before he eventually comes. And we still find that even today in my own part of the world. And then misconceptions about HIV transmission, you have to dispel and give them proper information, encourage consistent adherence to the HIV treatment regimen. And most times, it's the women that are consistent in taking their medication, but the men are hiding. That's my own experience. I don't know what's obtainable in your own environment. So we're going to have small group exercise, but I'm not sure we have time because I don't want to encroach into a British time. So it's an exercise that you do and discuss what is the incidence of HIV/AIDS in your communities. You can just report that in the chat or on the learning this is on the net. And then what resources are available in your communities for the referral and treatment of people with HIV/AIDS? Do you see any difference between how men and women are tested or treated for HIV in your communities? You would like to share or to have your own have you share your own experience about what's obtainable in your own practices or your own cultures. We'll move on. Tuberculosis, a common infectious disease caused by various strains of mycobacteria. Yes, and usually attacks the lungs but can affect other parts of the body Spreads through air when infected people cough, sneeze, or otherwise transmit their saliva. I know this knowledge is very basic for many of us, but it's just like a refresher. This is for us who work in the field of SUD, because you need to screen for all these things when you have SUD clients coming in, particularly for admission, whatever, you need to screen. So let's refresh ourselves and don't be bored. Because TB is an airborne disease, a person's social contacts also need to be screened and treated if necessary. Sometimes you find people with a family maybe with a TB, and then one person comes out with TB, but you find that interestingly, because some of them have very strong immunity, though he is among them, he's not treated, the other members don't even come down with the tuberculosis. But it's also good to look for the contacts and screen them, and if they are positive, you treat them before they come down with the disease. And 1/3 of the world population is thought to be infected with TB. That is scary. New infections occur at a rate of 1 per minute. In 2015, 10.4 million new cases and 1.8 million deaths. Largest number of new TB cases around occurred in Asia, followed by Africa. In fact, it's not even the new cases, but those that are becoming resistant to treatment. That is the greatest fear. What are the symptoms? Of course, this one is a basic thing for every one of us. Chronic cough with blood-tinged sputum, fever, night sweats, weight loss, various symptoms from infection of other internal organs. Sometimes it may be the first manifestation of somebody who is HIV positive, may come down with a tuberculosis, and we didn't know that they are even HIV positive. But we find clients who suffer from SUDs also come down with tuberculosis. 10% of TB infections eventually progress to an active disease, which, if not treated, will kill more than 50% of its victims. Yes. So 10%, the rest actually somehow overcome it, even though they may not be treated, but because their immunity is strong, they don't really come down with it. Treatment, there are various medications that are used for TB treatment. One is isoniazid and INH, rifampicin, ethambutol, paracetamide. I have very interesting cases with those who use isoniazid. Several times, patients who started on anti-tuberculous drugs, isoniazid, maybe within a week of treatment of inception, you find they will rush them to us that they are psychotic, and usually they become very psychotic, very aggressive, hallucinating, kicking, spitting, and being very destructive. And you ask, you don't find anything. Do they use drugs? No. What happened? Okay, he was diagnosed with TB, and then they started with drugs, and you see isoniazid, they say, oh, this is the culprit. And I've seen several cases that came down with psychotic episodes just because they started isoniazid for tuberculosis. So you have to have the high index of suspicion, and don't call people crazy because they have started anti-tuberculosis. And I used to assure them that he's not crazy. They say he's mad. I say no, he's not crazy. It's just a reaction to one of the drugs, and that helps the client and saves him from this unnecessary stigma. Diagnosis and treatment. Diagnosis: chest X-rays, TB skin tests, microscopic examination of body fluids, and so many other things are done. But medical treatment is difficult. It requires long course of multiple antibiotics. The problem is not even a long course. If they suffer from SUD or if they are mentally ill, they may not adhere to treatment. Problems with antibiotic resistance with a new virulent form of TB, and we are seeing a lot of them in my hospital. We have a session for those who have multi-drug resistant TB. And globally, TB infection rates of up to 59% among those who use substances have been found. 59%, which is big. And longer duration of injection, substance use, and older age are most commonly associated with TB. Interestingly, in our own facility, though we have people who inject drugs, but the ones that come down with TB and HIV/AIDS from our data are those who use alcohol. Most of those who inject, in fact, I don't, maybe hepatitis, but I don't see them with TB. I don't see them with HIV, like those who are dependent on alcohol. That is from our data. Our people reported in our journal. Drug-resistant TB. TB drug resistance is a major public health problem. Yes, and improper use of antibiotic medications is the TB primary cause of drug-resistant TB. And the improper use. When a patient is depressed, when a patient is psychotic, or when a patient uses substances, he might not adhere to treatment. But you find that most times they don't include or involve substance use professionals or even mental health professionals until we have to advocate for it. And then they saw the need to involve HCD professionals and also mental health professionals in the treatment of cases who have TB. And many of them are depressed. And many of them too are, alcohol dependent in my own client. But they didn't think of, involving us in the treatment at the onset until there was advocacy and some petition before they included mental health professionals. How does TB become drug resistant? Improper use of antibiotics in treatment of patients with drug susceptible TB. Administration of improper treatment regimens by healthcare workers. Sometimes it's the fault of healthcare workers or fail to ensure that patients complete the course of treatment. That's why now they treat them free, they give them a ward, they feed them, they do everything for them, and then they do the direct observation therapy to ensure that they take their treatment before they leave. Otherwise, it's drug resistant, then they go and infect other people again, and it's causing a lot of problem. So drug resistance arises in areas with poor TB control programs and people who use substances too. Multiple drug resistant TB. MDR TB develops when first-line drugs are misused or mismanaged. And of course, you can trust those who are mentally ill and those who suffer from HCDs to do that. It can take much longer and be much more expensive to treat with second-line drugs. Second-line drugs also have more side effects. Extensively drug-resistant TB or totally drug-resistant TB. Extensively drug-resistant TB, MDR TB, has also developed. In these cases, second-line drugs also do not work. That is, this one will give us nightmare, really. Treatment options are extremely limited. And even totally drug-resistant TB, TDR TB cases have been reported but not confirmed. And that's why we have to actually have very good TB control programs. We have to involve and the HCD counselors and the mental health professionals in the treatment of these people so that they adhere to treatment and reduce this resistance to treatment before they spread it to every other person. Problems associated with HCDs. Those with HCDs tend to already have a compromised immune system. That is true. Most of these drugs, particularly when you talk of alcohol and the opioids, that's lead to some reduction in the immune system, and then tend to be diagnosed later because of less access to medical care, are less likely to complete TB treatment, very true, contributing to drug resistance problems, transmitting the disease to others at a high rate. One thing the government has done is to get a place, treat them free of charge, feed them. Otherwise, I tell you, I know in my own place, they will not even want to stay in the hospital. They'll tell they don't even have the transport money to go to hospital. So to be able to checkmate that behavior, the government now gives them the drugs free of charge, admits them, feeds them, and takes proper care. Even then, some of them will still give the health workers a lot of headache. Counselors can help how? By educating clients about the disease. But for you to do that, they must be of sound mind, and you must be able to treat them for their substance use in recovery before they even apply whatever you are telling them. Help clients address problems with medication adherence. Partner with others in the community to help ensure that public health problems are addressed. In my own environment where alcohol is the #1 drug of abuse and it's a big problem, you find many of these cases coming down with multi-drug resistant TB, are people who also abuse alcohol or are dependent on alcohol. Unfortunately, there are no good policies concerning, alcoholic beverages. The government attempted, but the people resisted at the point that it's their culture and nobody can force them, to stop drinking alcohol. They have been drinking it before the governor of the state was born, and they don't see anybody who forced them to stop. They will drink it. It's part of their culture. So people can react that way. But we are still advocating, hoping that policies will be enacted that will help to control the use of alcohol. Small group exercise, this is where we'll come to the end. You have some few minutes, 4 minutes, to discuss the following two questions in small groups. I will divide the groups into regions, as you know I used to do. What is the incidence of TB in your communities? Everybody will answer it. North Africa, South Africa, East and West Africa. You want to know what the incidence of TB is in your community if you have any idea. But what resources are available in your communities for the referral and treatment of people with TB? Please, you can write down in the chat. The Jessica will help me maybe read one or two before Beatrice takes over. I still have 3 more minutes to play around. So let's please quickly do this assignment. So what is the incidence of TB in your communities? And what resources are available in your communities for referral and treatment of people with TB? Please, all the regions to answer. I want to have an idea of what is happening in your various regions. So very interesting. This is more like a refresher course for us, because I know that many people are conversant with what we have discussed, and some people may even be more involved in this than some of us. And then for the questions, please, I know there are very senior colleagues here in this program. It doesn't mean that for every question, the presenter must answer. Some of our senior colleagues may even have better answers, or they may be more knowledgeable than we are. So we also want you to help, in responding to some of those questions, because we learn from your own experiences. I know when we started, Professor Tafera used to, he actually contributed a lot, and I learned so much from his own experience. And I believe that other senior colleagues from other regions who are more experienced too can help us, give us their own perspective or their own experience, so that we share. It's not only for the presenters, it's supposed to be a very interactive one. In fact, for some of the questions, I'm supposed to throw them back to you, for those of you who have the answers to actually answer them. So let's, we have 1 more minute. Then Jessica will read. Or do you have responses already?
We have a couple of responses. Would you like me to wait a bit? Fine. Okay, so Fatima says in her community, they have a TB center for the treatment of tuberculosis and skin problems.
Oh, great.
And then Donald says that in Sierra Leone, has one of its tertiary hospitals solely for the treatment of TB and leprosy. A global fund provides technical and financial support. In Nigeria, Grace says it's very high amongst those in rural areas, especially farmers who abuse alcohol, and tends to manifest from the age of 60 years.
Very cool. Thank you very much. Any others? I want to hear from North Africa, South Africa, and East Africa.
All right, so one from Southern Africa, the TB program in Malawi is robust. They have community programs with cough monitors.
Great.
Let's see. I have another. Someone says they know that South Africa and Cape Town have the highest incidence of TB in the world.
Oh.
And they have good HIV TB programs with a focus on early identification and treatment.
Oh, that's great. They have the resources. That's good. So thank you very much for your responses. You can continue on the chat while Beatrice will take over. I appreciate your great participation.
Thank you, Dr. Moses, again for that elaborate presentation.
Thank you.
We appreciate your level of insights that you share with us. As you were talking about TB, I was reflecting on part of my experiences in the university with students who present with problems like not attending lectures, and they are failing in the continuous assessment, they are not doing exams. And then in my university, I happened to be in charge of the Directorate of Student Accommodation Services. So then I see them brought to my office because they are behaving, they say they are behaving funny, funny is the word used. And when they come, of course, I pick some psychotic manifestations. I refer them to the University Wellness Center. And what is surprising is how, like a case I recently had, it turned out they were abusing substances, alcohol and cannabis. And then the counselor discovered that they were coughing in the, when they were seeing them, and asked them what is one of their biggest concerns, and they said their chest. Sent them to we have an AIDS control unit, and which has got a lot of activities, including screening for TB. And the student turned positive for TB. So you can imagine he had SUD, he had tuberculosis, he was manifesting with what was looking like substance-induced psychosis, but which could as well turn out to be a co-occurring disorder. And really what I realized was very critical and important at that point was the whole idea of case management. So when I listened to Moses present about TB, about HIV, I think of ourselves who again have university students, and I think that we have to take this knowledge seriously and think about how we can start case management programs in our institutions to support some of the students who may actually be struggling with co-occurring medical disorders, because I have found they are pretty common. So next and finally, we are coming to the end of our course. We're going to look at hepatitis. Again, like Moses said, this is basic knowledge for those coming from medical field. For those coming from non-medical field, it isn't basic. It is actually a new knowledge for many of us. And so we do not take it for granted that, some of us may know this very much, but some find it new. And by the way, I was, for those of you who might want to sit for the credentialing examinations after this, you realize that in the ICAP exams, a lot of questions are tested on this specific part of the curriculum, the co-occurring medical disorders. So even if you're not coming from medicine, you are not going to say that this is stuff for doctors, I don't need to know. You got to know it because, like we said, this is a multidisciplinary sort of field. So that's why all of us have to acquire some basics of every single discipline. So looking at hepatitis, it's a viral infection that's characterized by inflammation of the liver. There are many types of hepatitis, like we can see A all the way up to E, but the most common are A, B, and C. And it's been found that B and C can lead to chronic disease and serious damage of the liver. Some of the methods of transmission, they slightly differ for the different types. So hepatitis A, basically fecal and oral contact. I have encountered hepatitis A among some of our university students who choose not to eat in the university restaurants and eat outside in the neighboring environments, which might not necessarily be as well sanitized. So this I have seen this. Then we have hepatitis B, which is transmitted through blood and sexually or infected fluids. And of course, hepatitis C, blood, but also sexually transmission is uncommon, but can also be possible. And of course, when you think about these modes of transmission, then you begin to think about our clients with SUD and how SUD makes them live certain kinds of lives. If, for example, they are using substances through injection or injectable drugs, then you know that then they are at risk of hepatitis B and hepatitis C. Sometimes people who use alcohol and other drugs could find themselves in very, dingy environments that are, not well sanitized. So you find that many of them can actually catch even hepatitis A. And I know, like Moses said, even in our country, we have a couple of people with alcohol use disorders who also present with cases of tuberculosis, maybe because of the congestion in the places where they go to drink, particularly when they reach the stage where they are looking for any kind of alcohol that can sustain their addiction. Now, in terms of symptoms, it's noted that most people who have chronic hepatitis.
Sorry, Ma, we can't share, we can't see your slides, please.
Oh, really?
Yes, from the beginning.
Okay, what about now?
Not yet.
I can see it.
Okay, let me try sharing again. Let me stop sharing. I try sharing again.
We can see it.
Okay, so I am sharing afresh. Please let me know whether you can see now.
We're seeing it.
Can you see now?
Yes.
Can see it.
Okay.
Yes, we can see it.
Thank you for that. So what we said at the beginning is that hepatitis is viral. It's characterized by inflammation of the liver, and there are many types, but the most common is A, B, and C. And we said that B and C can lead to chronic disease and serious damage of the liver. We also talked about the modes of transmission. We said hepatitis A mainly through fecal and oral contact, B through blood and sexual transmission, and C largely through blood, but can also in rare situations be passed sexually. And I said that because of these modes of transmission, people who use SUDs then are likely to catch these diseases, because if you're injecting substances, then you're likely to get infected through body fluids for hepatitis B, and also for hepatitis C through blood. And that's why, again, Moses talked about why some countries, have programs that they call a harm reduction, where they do needle exchange to try and reduce the incidences of infection with hepatitis B, just like HIV/AIDS. And we are now talking about some of the symptoms of hepatitis B, and we're saying most people will have hepatitis but not necessarily know it. Some of the symptoms could include, symptoms which often present like flu, things like feeling fatigued, generally feeling unwell, headaches, muscle aches, low-grade fever, lack of appetite, and weight loss. So it's possible for someone to have hepatitis and miss it. There is a colleague of mine who was there, who had gone actually for routine tests for insurance purposes. And so they do all this range of tests, and it is actually in that test that he was diagnosed with one of the hepatitis, and he had no symptoms. He had not even thought of anything. So now he's on a long-term treatment for that. So this can actually happen. Other symptoms include nausea and vomiting and abdominal pain, jaundice, where you have got the yellow tinge on the skin and the mucous membranes. Then you have diarrhea, itching of the skin, dark colored urine, and pale bowel movements. Why it's called the silent infection is because, like I have said, people can actually have chronic hepatitis and remain symptom-free for decades while the liver is silently being damaged. Hepatitis C is particularly problematic. We're saying that a person may not experience symptoms for a long period following infection, and so may not know they are infected. So the virus can become chronic, and those with cirrhosis can develop liver failure and other complications, and treatment can be difficult and prolonged. And of course, now with our alcohol using clients, they could have cirrhosis. And now when they get hepatitis C, that can complicate the problem. Most cases of hepatitis B will resolve without any treatment. Only about 1 in 5 people with hepatitis C will clear the infection without treatment. And of course, we have got the standard treatment for hepatitis C, which is indicated here, the various medications. This is best understood by those of us who are doctors. Now, some of the new treatments are also listed here. There are very, very many. You can read them, you can discuss them in our chats across. Those who are physicians, share your experiences of using these different regimens of treatment. It's good to note that antiviral treatment is difficult because it generally lasts 6 months to 1 year and can even extend longer. That should tell us something about our clients with SUD. Already adhering to any medication is a problem. So when you have a long-term, treatment, that becomes even more challenging, and they will need a lot of case management. Then of course, adhering to the precise medication protocol is critical, and managing side effects can be really difficult. In cases of extreme liver damage, liver transplant may be the only treatment. And I tell you, I do not think in our countries in Africa, many of us have even come anything close to being able to do liver transplant. So this might just be a dream or a mirage for many of us. Now, worldwide, about 2.3 million people with HIV are also co-infected with hepatitis C virus. Of course, remember the blood-borne methods of transmission is what they share. approximately 1.3 million people who inject substances. Now that is important because it means that 1.3 million people are at risk of catching HIV, are at risk of catching hepatitis C. The greatest burden of HIV and HCV co-infection in Eastern Europe and Central Asia, particularly among persons who inject drugs. I think that is expected. In Sub-Saharan Africa, statistics suggest that they account for 19% of the cases. Now, HIV and the hepatitis C have parallel paths. This is because of the risky injecting and sexual behaviors, which create high risk of transmitting both infections. Currently, we are saying hepatitis C is 5 times more widespread worldwide than HIV because of the fact that it's more infectious and it has been around longer than HIV. Now, in terms of SUDs and infectious medical disorders, we note that SUD increases the likelihood of a couple of things. One, the high-risk sexual practice like unprotected sex and multiple partners. Why? Because of impaired judgment. There is lower inhibition because of some of the substances that are used. You know, for example, that alcohol will reduce inhibition and cause some level of excitability that causes people want to reach out to partners. Now, transactional sex where people trade money, sex for money. Today, I was actually reading an article in one of our national papers of people trading sex to get food during COVID-19 because of the hardships of the economy. And so you can see how transactional sex can be a problem in terms of infectious medical diseases. Of course, the third point is spreading infectious diseases like TB because of lack of self-care and access to medical care. I guess that would explain why many alcoholics or persons with alcohol use disorder, because of the lack of self-care, will obviously not even have the access to medical care, will then have high incidences of tuberculosis. Now, does treatment of SUD help? Yes, there is evidence that if you treat people for SUD, then a couple of things happen. You reduce the overall risk of HIV infection. You increase the likelihood of the high, Moses told us about the heart treatment, slowing progression of HIV. So it means the outcomes become better. And it does these things cost effectively, especially compared with costs of treating the consequences of AIDS. I think the message in this slide is, and I think governments have realized that if we treat SUD, we then indirectly help reduce the burden of HIV. And so in our country, I noticed that the only government SUD treatment facility is actually set up in a mental health facility. And the history of setting up that had a lot to do with setting up an SUD treatment center to reduce HIV infection, because much of the funding was HIV related. Now, it's difficult many times to get funding to support SUD treatment, but it gets easy to get funding to support diseases like HIV or TB, which then would mean we can anchor our SUD treatment programs within HIV, treatment facilities or programs. And I think that is what helped our country to set up the first SUD treatment in a mental health facility. Of course, it does admit everybody, even those who do not have HIV infection. What role can counselors play? And I think this is very important. Remember, we say many times, clients may not even know they have these diseases. So they present themselves to counselors for SUD. And families present these people to counselors for SUD. But counselors can help by educating clients about methods of transmission, as well as treatment options available for all these medical conditions, whether it's HIV, tuberculosis, and hepatitis. At the same time, counselors can play a role in teaching clients about safer sex practices. I was having a discussion with someone in my university about students who are not able to go back to their homes because of the challenges of COVID-19. And I was asking, so what are they doing with their time? And I remember one of my colleagues telling me, at least we are providing a means of protection against HIV, because it is likely that those students may be having more time on their hands and more freedom, and they could actually begin to engage more in sexual practices. So when we teach clients about safer sex practices, when we provide them with methods of safe sex or protection, distribute condoms and lubricants, when we provide referrals for medical testing and care as part of our treatment, that will be helping to control the spread of these medical conditions. The other thing that counselors can do is to actually maintain a close contact with the medical treatment providers. This is critical because sometimes, and this I have seen even in my own institution and my own country, where our treatment models are so isolated. The doctors are isolated in their silo. The counselors are isolated in their places, but just being able to connect in some form of case management can help us in terms of ensuring that we are linking up clients to support services, and we are also following up, the kind of medical treatment. So in my university, like I explained, one of the things I have seen, sometimes our Directorate of Health Services works with myself, who's in charge of accommodation, and they tell me there is this student who has got this TB, and it has been highly resistant, but now it's under control, it's no longer infectious. We would like to have them near this health center so that they can be able to be monitored as they use their medication. And so could you please provide them with accommodation in the university? And I find that when we have that kind of deliberation, we are able to offer better support to these students. And so I think that point of maintaining close contact with the various treatment providers is very critical for counselors. We need to provide support for clients undergoing testing and treatment. I think for me, these I have again seen as a big thing. Like I said, my university have about 10,000 students who live on campus. And so sometimes students will come to my office and I'll be informed that they're having a problem taking medication because they are afraid of their roommates seeing them taking all this medication and the issue of stigma. And I have to take an extra step to educate the roommates, to probably provide them some accommodation space that is a little more private for this student so that they can be able to continue taking their treatment. So just that contact and the networking between different service providers can be very, very important. And finally, of course, the whole idea of helping to monitor medical adherence. This is important for counselors. And I also think counselors can do a lot of advocacy for clients with regard to adherence to medication, with regard to support for treatment after testing. Other things that our programs can do, they can actually provide education regarding infectious diseases. They can provide information about testing and treatment options, as well as link clients to the testing and treatment facilities. And of course, they can provide information on availability of SUD treatments. Now, we have got an exercise here that we will not necessarily do now. We will look at it in deeper detail in our discussion. But what are some of the things we want to think about in this activity? We want to think, what is the incidence of hepatitis in our communities? How does it compare with HIV, AIDS, and TB that you reported? And when Moses was speaking, what resources are available to refer people for treatment with hepatitis, or people who might have more than one of these disorders? So we will discuss more of this in our discussion, but because we have a few minutes, I'll give you a chance to raise your hand and say something that you might say about your country. So does anybody want to raise their hand and tell us what kind of problems they have in their country with regard to hepatitis, and what kind of programs, and if anything is available in terms of community resources? Jessica, because I can't see the charts, yes, but Grace has raised her hand. So Grace, kindly respond, share your experience. Yes, Grace, please unmute yourself. So Jessica, can you unmute Grace?
Yes, oh.
So
I am asking
yeah.
Grace to unmute. There we go, I think.
Okay, so Grace, are you unmuted?
Yes.
Okay, please go ahead.
We have more knowledge about the HIV and AIDS more than that of the hepatitis. And most times, since it's are not really shown. People tend to carry a long period before they are being diagnosed. So even when they are being diagnosed, some of them just take it with that kind of nothing will happen. I can use maybe medical way. It's just sufficient that we notice people trying to go there. Then in the aspect of referral, we don't really have much centers now because people always the sponsorship of HIV than that or hepatitis. Hepatitis maybe in Lagos or maybe far Abuja.
Okay. Thank you, Grace. So thank you for that sharing, Grace. And I think what Grace is talking about represents many of our countries. So we need to think about what resources do we have, what advocacy can we do as counselors to try and enhance access of our clients to these support services. Any other hand that's raised, Jessica?
I am looking through.
Or any response in chat?
See any others
yes?
right now.
Okay, any chat?
Nothing new, no.
Okay, thank you very much. So I do think in summary, what we want to emphasize around this final module of co-occurring medical disorders, there could be many others, but those are the three most common in the SUD field among clients. I think the most important thing for us as counselors, thinking about ourselves as counselors, because of course there are those who are medics who are actually treating these diseases, but from a counselor perspective, an SUD counselor, the most important thing is that you have a responsibility to be on the lookout, to provide information to the clients, to encourage them to get tested, to connect them to the facilities where they can get tested and treated. And once that happens, to offer what we call supportive psychotherapy, where you continue supporting them as they continue with the treatment and as they continue with the adherence. And I'll tell you, one of the biggest challenges I have found with this, like you have seen and Moses has told us, each of these conditions requires either long-term treatment or lifelong treatment. Now, adhering to medication is difficult. So supportive psychotherapy, whereby we work with the clients towards understanding what are their concerns about the treatment, what challenges are they experiencing around the treatment, can be one of the biggest contributions a counselor can make towards adherence. I do know I have met clients who stopped taking medication, and when I asked them why, they said it's because I Googled in the internet and I found that this disease, this drug causes people to become impotent. So I stopped taking. Now, you see, that's a legitimate reasoning by your client. So I asked them to go and have that discussion with the doctor, the prescribing doctor, and the doctor is able to explain to them and to tell them the different, options they have. So it's important when as counselors, we take time to listen, we take time to explore what the client is going through as they continue with that treatment. Sometimes it's the stigma that they are facing. I have met this a lot with students who have HIV and they stay in the hostels with fellow students, and they are saying they stop talking to me, they stop associating with me, and I have to do a lot of advocacy for them amongst those that they share rooms with. Sometimes I have to shift them from one place to another if it is so critical. And these are things we can do as counselors: supportive psychotherapy and adherence therapy for our clients. So thank you very much. We have come successfully to the end of our UTC 3. Thank you for having been very great participants. It's been a heavy curriculum, like you noticed. And we said we were not training you to be psychiatrists or medical doctors, but we were giving you basics that can make you be able to see when there is a problem, as well as to support your client to access services for some of the conditions we have talked about. Keep increasing your knowledge, keep interacting with fellow professionals, because by so doing, then we enhance our knowledge. Otherwise, thank you very much. And I wish you a successful time as we consider moving to the next level. So I now invite Kim to take it up from there. Thank you very much, Jessica, for your support.
Thank you, ma'am.
Thank you.
Hi, everybody. So the post-test is available in the learning management system, and there's also a course evaluation in the learning management system. I think I've gotten everybody settled and into it, but if you still are having trouble, send me an email. And once you do the post-test, the little box that you check that says that it's complete, And that will then,
And I'm Manuel.
you will, you'll have access to the trainer manual. So I think that's everything you need for that. We'll start the UTC for the day
Friday.
after tomorrow, Friday. And I have that set up in the learning management system too. So if you want to complete the post-test UTC and then go ahead and complete the pre-test for UTC4, go ahead and do it all at the same time. And we'll get you the link to the Zoom meeting tomorrow. We'll get it sent out via email and we'll post it in the learning management system by tomorrow. So is there anything else I need to say that I've missed?
Just to tell them that UTC4 will take 5 days.
Yes, thank you. 5 days. So we'll start Friday, Saturday, Monday, Tuesday, Wednesday. So it'll be similar to this week. And then Beatrice says after that, they're not so heavy for a couple sessions, right? These are all very content heavy. And the UTC4 has a lot of activities, and one of the things we're going to talk about when you all hang up is how we can actually incorporate some more activities in that session. So we'll let you know. Have a good evening, everybody.
Bye, everybody.
Bye.
Hi, everyone. Have a
Bye.
good night.
Bye-bye.
Yeah, bye-bye.
Bye, everyone.